I'd now like to invite all the speakers for this session. I'd firstly like to welcome Ms. Anagha Walanju, the Chief Information Officer, Somaiya Hospital and Research Center. Let's give a huge round of applause as we welcome our panelists and speakers. I'd now like to welcome Dr. Milind Khadke, the Director of Medical Services, Jaslok Hospital and Research Center. A huge round of applause for Dr. Milind Khadke ji. I'd also like to welcome Dr.Hardik Kumar Ajmera, from Medical Director from Saifee Hospital, Mumbai. Let's have a huge round of applause for Dr. Hardik Kumar Ajmera, clearly the judge for today and speaking for us as well. And last but not the least, may I please invite Mr. Neelesh Shinde, the Group Chief Technical Officer and Head, Projects, Jupiter Life Hospitals Limited. Let's have a huge round of applause and over to our moderator. May I also invite Dr. Kunal Sharma, the Vice President and Head Integrated Onco-Pathology, Agilus Diagnostics. Let's have a huge round of applause for Dr. Kunal Sharma in the house. Thank you very much, sir, and over to you, sir.
Thank you so much. Welcome all of you. Thank you so much for your precious time. And welcome Dr. Kunal as well. Pleased to meet you. So I see that energy in the room now. Fantastic. Good morning, all of you. So just to introduce all of you, myself, I am 𝗂𝗛𝗱𝗆, working as Director of Emerging Markets, Asia Pacific, Japan, and Middle East and Africa with an organization named as DocBox. So we are into medical IoT solution for intensive care units, operation theaters, and we are also into tele-ICU solution for remote monitoring of the patients. I have a session post-lunch, so I'll request all of you to please attend that session for 10 to 15 minutes. Now coming on to this session, I'll welcome to the panel. I'll introduce, ma'am had introduced, so I'll start with the speech now. The topic today is your hospital ready for AI? So we all are talking about AI today, a buzzword being spoke globally. We recently had an AI summit in Delhi. It was a huge success and we saw the global attention over there. So the panel is your hospital ready for AI? Infrastructure, data, and governance. The moment we are in, India's hospital sector is no longer asking whether to adopt AI or not. The real question is whether it is actually equipped to do so. And the Indian healthcare AI market is growing at a rate of CAGR of 40.6%, which is quite high. Yet the foundational readiness required to deploy AI responsibly remains uneven across the sector. For every hospital that has successfully integrated AI into diagnostics or clinical workflows, many more are still reconciling their HIS with their PACS or working with data that is neither clean nor structured enough to train or trust a model. Now this panel begins where the real work begins, not with the technology, but with the institution. Now why this conversation matters right now? This conversation definitely matters because the infrastructure and governance question is no longer a back office concern. It sits at the center of every credible AI deployment decision. Globally, the most common reasons AI healthcare implementations underperform or shall are not algorithmic, they are organizational. With a poor data quality, siloed systems, absent oversight structures, and untrained teams consistently emerge as the primary barriers to value realization. We all agree to that. In India, the challenge and the governance question is no longer a back office question. And in India, the challenge is compounded by scale and heterogeneity. A large hospital network in Maharashtra may operate across facilities with dramatically different levels of digital maturity. A pathology pipeline, a diagnostic chain must reconcile AI readiness across imaging systems, laboratory workflows, and pathology pipelines simultaneously. We all had seen that with over 282 million consultations processed through AI-assisted platforms like eSanjeevani, and regulators beginning to articulate expectations around AI oversight, the cost of being underprepared is rising fast. Now what this session will cover today. Over 30 minutes, we are going to see that the clinical decisions, technology heads, and diagnostic specialists from some of the Mumbai's most prominent institutions will address 5 readiness dimensions that matters most to the hospital leaders in 2026. What are those 5 ones? The data maturity. What level of data quality and governance is genuinely required before AI deployment And how do hospitals honestly assess where they stand right now? Second one, system integration. What does meaningful integration across the HIS, PACS, and EMR actually involve? And where do most of the hospitals underestimate the complexity? The third one is very important, which is a governance model. Who owns the AI oversight inside a hospital? And what frameworks are emerging as practical standards for accountability? Skill gaps, very important factor. What capabilities are hospitals missing the most? And how are leaders building or sourcing them? The readiness threshold, at what point is a hospital genuinely ready to deploy AI responsibly, and who makes the call? So with that being said, I'll now pass on my questions to the panelists. All of you are aware we have Dr. Kunal Sharma. Pleased to meet you, Dr. Kunal, who is Vice President and Head with Integrated Onco-Pathology's Agilus Diagnostics. So we'll have 2 rounds. I'll quickly try to cover in short span of time. So Dr. Kunal, my first question goes to you. In diagnostics, AI is only as reliable as the data which is feeding it. Now, what does data readiness actually look like in a high volume pathology and imaging environment, and where do organizations consistently fall short before they realize it?
I think it's a very pertinent question. Agilus being the largest diagnostic player in the country, for a diagnostic player of our size, I think what is most important about data readiness is the interoperability of data and how our pipelines function. So I think we can subdivide it into first, what kind of data are we talking about and how it has been validated. So it's very important that your data is validated across heterogeneity, because there are different kinds of population that we have, and also that there is a correlation that has been done during validations between the data or the AI algorithm being used and the human, that is the pathologist. Another very important aspect of what we do is called data plumbing. So what we need to understand is that before even exposing that data to your AI algorithms, a lot of that data needs to be cleaned because most of it is noise. True. So we call that data plumbing, and it's very effectively said that garbage in, garbage out. If you put garbage data in, what you get out is garbage at the end of the day. And some of the things that actually prevent it, and we need to be careful from an administrative standpoint for our kind of setups, is that, as we know, that we have something known as dark data. And what is dark data is, let's say we digitize our pathology slides. So a lot of that just stays in the archivals in many institutes. We need to make sure that this data is actually communicative, and these data don't stay in silos. So your PACS should communicate with your LIS. Your histopathology report should communicate with your genomics report and your clinical findings. And that whole clinical metadata is available when you're analyzing this data. So I think these are certain points that that we really focus upon as far as data readiness goes.
So true, Dr. Kunal. Thank you so much for a brilliant answer. So my next question goes to you. I would just like to introduce ma'am is Miss Anagha Walanju. She is the CIO with KJ Somaiya Hospital and Research Center. Ma'am, HIS, PACS and EMR integration, it is siloed right now and considered constantly as a prerequisite for AI. Now, but rarely described honestly, what does that integration work actually involve, and what do hospitals' leadership teams typically underestimate right now going into it?
So basically, when we talk about integration, it is always misinterpreted that it is just the connectivity between the systems. Yes. That is HMIS, yes, EMR and yes, PACS. Yes. But actually it is not about only that connectivity, it is how the data flows from one system to another system.
So true.
And that is like, I can say, the correct data and in a correct manner.
Yes.
And complete.
Yes.
Complete data. And the consistency should be maintained. So what is presently the main challenge in the system is not technology. Technology is just a path which the data will follow. But the main challenge is the data. So the maintaining data quality, then keeping that data secured.
That's very important.
And then utilize it for the better. Like if your data is not in the standard format, then different systems will evaluate it differently.
So true.
So the integration, like nowadays we see everywhere you have the easy connectivity throughout the areas.
Yes.
But just imagine, I'm telling you that, okay, with this road, you will reach, instead of 1 hour, you will reach within 15 minutes. But imagine that road is not smooth, not seamless, then you will not find it better. You will say, okay, let it take half an hour, but more 1 hour, but I will go with the road which is, clear and smooth. Same way goes in the system. If the path or the connectivity is there, see, once you implement the integration, then it is, means really you don't have to do anything in that. It is on place. But what is recurrence is your data. So which is flowing regularly from your one system to another, and that needs to be accurate, because if that is not handled carefully, then what AI will give you is not the accurate data.
So
and then
true.
the patient care is at stake. So that is the thing.
100% I agree with you. So the data has to be very, very, I'll say, structured data, and it should be normalized data.
Normalized,
That's what
it should be in the proper standard.
proper
also
standard form.
Because, otherwise it is, means we are ruining the complete process.
So true. So true. Thank you so much, ma'am. Any cross question from the audience? Sir, please. Yes, sir, please. Can you please introduce yourself and ask the question?
Hi,
Hi.
I'm Dr. Aman Kapoor, and first of all, Dr. Kunal, I keep saying Gigo a lot to people, and it goes bounced off. You're one of the first people, I have heard saying Gigo, and I believe this is the foundation of any technical, your output can be as good as the input only. Now, the challenge, as both of you, ma'am, and Dr. Kunal, both of you have said, that is that quality of data matters, because ultimately that is going to make our output. In the Indian architecture of hospitals, EHR or EMR adoption is still miles away. Miles away. I have worked with organizations previously as digital healthcare at GM and all, and I know that everything is in a silo, and every data has a different format. So we have a data lake, and that lake is having unstructured data which is spread across in formats. So I agree with your point that data has to be structured. But again, the pain is, if you look at the front-end user, that is a doctor or a nurse or an attendant or a receptionist who has to fill the data, they don't have time. One. Second thing is, they see all of this structured work as painful. So how would you suggest to bridge this gap? Where can you take raw, messy data, use AI to structurize it, and at the same time make it simple for the end user? Because if they don't adopt to it, it is not going to happen. I have seen case papers being filled with information that leads to nowhere.
So I would like, this is very nice point. What happens, people are, what I understood from my experience, people are not, resist to do the, or to adopt any new initiatives. They resist because they are not aware of the process. So first and most important thing is, when we introduce any initiative or any new adoption, we are not considering the proper training and awareness. So most of the time, what happens, the counter people, everybody, not even counter, at the even level of the clinicians, they are very much afraid that, okay, now AI is coming, now he will steal my job. So the security of job, which is there. And the second important thing is awareness. Why we are doing this? To make the life easy. So giving the proper guidance, awareness, and then the training. Once, and I feel each and every person, individual who is involved in this process needs to be properly trained and involved in each and every activity, so that they are aware of why we are doing these initiatives, what is the logic, and how we can achieve this, and then how our life become easier. Once that is clear and they build a trust, then they will do it themselves. So people like to do what they understand better. So that is what I think what is needs to do is the awareness and the proper training to the end user.
But again, lot of time the initiatives flow from top to down. Management takes the decision and then it comes down. But adoption happens from down to up. So now, I mean, there was a vision of mine at one time which I dropped the idea. I was thinking of developing an AI-enabled EHR system, and where the doctor could just dictate the notes, it would transcribe, it would take the information, fill in the form, the doctor would have to just click, okay, yes, verify and click send. Because the doctors are used to writing down on this, and we don't understand our own handwritings also, forget anybody else. So how those challenges are there at the bottom line. I love AI. I have used it so much that ChatGPT अगर इंसान होता तो मुझे बोलता है कि just shut up for now, you know. So I see both the sides. I mean, I would love to have this happen, but again the question is कि how do you make them feel कि yeah, this is going to make my life so easy.
So I think I'll take an extension from her answer, and she has made the ground very simple for me. I think the question that you are asking actually pertains to human behavior most. That we, as she rightly said, are very used to familiarity. And to break that shackle is a difficult proposition for us. So I'll tell you what we have done, for example. So when we were adopting digital pathology and digital reporting, you come across companies who say that we will, do away with the microscopes. Doing away with things that have lasted for years is never the right approach. What we actually did was that we let the microscopes be, and we also introduced digital reporting so that our pathologists get used to the flavor of digital reporting while the familiarity of microscope exists. And there, they slowly start adopting the digital side because they see that counting mitosis is objective, counting Ki-67 becomes easy, and also it gives time for these AI systems to become more validated and set in the process. The second part to your question was the top-down approach. I completely agree with you. And I think there what can help is probably a digital or an AI governing committee in particular institutions which see that deployment of this is very seamless. Because what happens is, let's talk about government hospitals. Most of our nurses are actually running away to make sure that discharge summaries are signed, records are in place. You give them that you have to enter this data into the system, they'll treat it as additional work. You have to pitch it to them in a way that they feel that their work becomes easier. Whenever humans feel that something makes their work easy, they will use it. The moment they feel it's a competitive antagonist to them, they will probably, all of them will gang up and say that this is useless, let's do away with this. So I think...
Thank you very much.
Thank you.
And second thing is, it is ongoing process. Where is the hurry?
Yes. Thank you so much. Thank you, Dr. Kunal. Thank you, ma'am. So my next question goes for Dr. Milind. Hi, pleased to meet you, sir. Dr. Milind is Director of Medical Services with Jaslok Hospital and Research Center, Mumbai. Dr. Milind, from a medical service perspective, how do you assess whether your hospital's data infrastructure right now is ready for AI deployment versus it is ready on a paper?
So if anybody says the hospital is ready for AI, I would tend to disagree with him 100%. Because none of the hospitals right now are ready. Because when you're talking of AI, your HIS says, and EMR integration should be up to level 7.
So true.
I think even here in our in Indian setups, we have only finance, pathology, laboratory, some of the billing, etc. Online. But main thing is the patient records, not much online. If we are talking of AI, the patient records, which are like clinical history, investigations, etc., everything has to be combined, and that AI will help us read the opportunity of treating that patient in a particular way. So here, it has been said multiple times here in this forum itself that we need EMR 100%. Then we talk of cleaning and plumbing the data. First, we don't have data online, which is the main important crux for the patient care and treatment. So definitely there is a long way to go. In our hospital, we are trying to put multiple resources to just get the OPD's documentation online. So we have 3 to 4 different types of documentation, OPD documentation techniques. One is speech to text, one is what Dr. Aman said, some conversation will be taken up into a prescription model. Then one is the writing model, by तुम्हें अच्छा लगता है लिखना अच्छा लगता है, write it, it will get converted into electronic form.
Text, yeah.
So there are multiple things that we are trying, and even in IP, I think when the patients are admitted, if we are asking them to write, we've given them multiple resources, tablets, computer on wheels, but there's a lot of resistance. Like she said, this resistance has to be overcome by telling them that this is for your own good. So what I basically tell them, my hospital is very research oriented. I tell them, if you have data, your research papers will come like
Yes.
So the second thing, when you're following up the patient, you don't have to go through papers. If he doesn't get the papers, then definitely there will be something online. So this is the basis for AI. There are multiple other things that we are trying to do, like predictive ICU monitoring. Predictive is better than reactive, we all know.
True.
But we don't have a standard model right now for predictive. So that we are trying to look into by putting various pilots. So there's a lot to do, I think, in this.
There is such an honest answer, Dr. Milind. Thank you so much, and I hope all of us will agree with this answer. Such an honest answer. Thank you so much, Dr. Milind. My next question goes to Dr. Hardik Kumar Ajmera. I'd just like to introduce Dr. Ajmera. Dr. Ajmera is working as a medical director with Saifee Hospital, one of the biggest hospitals in Mumbai. Welcome on board, sir. Dr. Ajmera, as a medical director, you are accountable for both the clinical outcomes and institutional risk as well, a major one. Now, what is the infrastructure question you ask first when evaluating an AI solution before anything else?
Thank you. And thank you, DHN, for inviting me here to be on the panel as a part of this esteemed panel here. So coming back to your question, the thing is when I evaluate as a medical leadership or as a medical director, when I evaluate any tool, any AI tool for the hospital, yes, definitely the two things on my mind are, is it going to improve the clinical outcome, number one, as you rightly said.
Correct.
And is it going to reduce the risk for my institute, as in risk for my patients? Is it going to improve patient safety? Or, as somebody said, is it just going to add one more layer of documentation or additional work without additional resources, which may actually be more challenging for the people? Correct. And it may be counterproductive. So that's the question we need to answer while choosing any technology for the hospital.
Yes.
Because technology, when we choose, is not just an additional app in my mobile. It's like adding a team member, a clinical team member to your team who has to be safe, reliable, secure, and maybe accountable. So the technology also has to behave in this era of AI as a clinical team member who will work with you and has to be reliable. So let me give you some use case. Like, we are in the process of implementing many AI enabled AI-based solution in our hospital. So when we started with our EMR, so first thing is, we deliberately did not go in for a EMR for the last 10 years or 15 years, though it's available in the market, because all those EMRs were where data had to be input using either a computer or a mouse or a tablet, anything.
Yes, yes.
Now that there are voice to text engines available, yes, and I can see 3 of them here, ICA-Care, HealthRay, and AstraScribe.
Yeah.
They all, and a similar AI-based EMR is what, which is user friendly, we are trying to enable, where you have to give a dictation and all the relevant fields are just auto-populated based on the dictation. So that's the kind of, first it has to be user-friendly. Now coming to your question, it has to also give a layer of patient safety. So we start with basics. Is this EMR flagging drug-drug interaction, maybe drug-food interaction, therapeutic drug duplication? Is it giving me reminder when my medication dose is missed? So we start with basics like that, okay? Second, so this is maybe one pocket of EMR. Correct. Secondly, we have a second pocket where we have remote early warning sign monitoring system on every bed of the hospital.
Yes.
From where the vitals are captured and a alert is given in level 1, level 2 or level 3 alert is given for the nurses or the doctors to act on it. A third pocket is maybe we have a AI enabled system in our lab where the blood sample from collection till report dispatch passes through 8 gates. They call it gates, where every gate will check it for reliability, accuracy of the report. One of the gate is comparison with the previous values of the same patient in the same admission or previous admission. So there are various gates. Dr. Kunal will know better about those technical gates.
Yeah.
However, now what we have, and we also have a fourth pocket where we are looking at clinical algorithms or clinical decision support systems, which will guide the clinicians. So we are working in these various pockets with AI, but now we are looking at building an ecosystem where the clinical notes from the EMR, the vitals captured from my monitoring system, the lab values, and my clinical decision support system, which has my standard treatment guidelines, all will now talk to each other and now tell me if a sepsis risk is there, if the patient is going to deteriorate, maybe am I ready to discharge the patient, or is there something else needed? Is my doctor following the treatment guidelines as per the latest up-to-date guidelines? And so on. Is there a risk of readmission or readmission to the ICU based on all these parameters? So that is the next level of ecosystem which our hospital is trying to develop, and maybe a lot of others are trying to do that. Now, while doing this, we can all see that, okay, risk, as you said, and the clinical outcomes will improve. It's no brainer, whatever I just mentioned is going to help us increase the productivity, increase the safety net, and also maybe increase the clinical outcome. Okay. However, the question is, what if my lab system is not giving the critical alert as it is designed to do? What if my monitoring system is giving me a false reassurance? What if my drug-to-drug interaction is not capturing all the latest up to date from the database?
Yes.
So these are some of the challenges, because AI is evolving, AI is learning, the maturity models are evolving continuously. So as responsible clinicians, we have to look at these decisions very carefully before implementing any AI model. That yes, and there are some questions, if time permits, there are some models or frameworks, how to do it effectively. If time permits, maybe we can again deliberate on that.
Sure.
That how can we do it safely and not fall into the pitfalls of the AI, because even if you open Gemini, it says the first sentence is, this is generated using AI, which can make mistakes. But so can human beings.
So true, yeah. This is such an honest answer. Thank you so much, Dr. Ajmera, for that answer. Fantastic. I'll now move on to Mr. Neelesh Shinde. Mr. Neelesh right now is working with, as a Group Chief Technical Officer and Head of Projects with Jupiter Group of Hospitals. Neelesh sir, what is the honest state of infrastructure readiness across large hospital networks in India today? And what is the single most common gap you encounter when you are assessing an AI deployment feasibility?
So first of all, I would like to thank DHN Network for giving this opportunity. And the first line which is written here, AI vision meets healthcare reality. So I'm going to talk only of reality, okay? Because I'm not from the software side. I'm a guy who's a founding member of Jupyter and take care of greenfield projects. So I believe that first thing when we are talking about AI, the first thing is that what is important is that what is the base what we are having. Here we are not talking about the hospitals, people who are sitting on dais, okay, they are having a lot of things available in their own organization. But if you say across India, because we are talking about across India, so across India, are we ready for the basic thing? Basic जो लगता है as a project, एक कोई server room करने के लिए, whether we are prepared for that. आप जब भी drawing board पे देखोगे, drawing जब architect drawing बनाता है, whether he or she is ready to give that much space to the server room? Because we are talking about still on-site server. Still long time to go when we'll go for cloud. Everyone cannot afford to go for cloud because of commercial reason. And cyber security is also one of the things. But I'm talking about on-site server. So what are the basic things on on-site server? There are like, we are having a server room as well as we are having hub rooms on the each floor, okay? Now, for the server room, the basic infrastructure is like what normally we require a power without fluctuations. Okay, simple thing is required. Everyone is aware that UPS देना है. But UPS को backup है कि नहीं? God only knows. जब problem आता है, then everyone realize that, oh, that backup is not there, server has gone down. Now, to be realistic, you know that the importance of CIO came into picture only after COVID. So, I can say because of COVID only people started learning who is CIO.
So
Otherwise, CIO means वो internet का मेरा email address करना, ये internet देना, मेरा printer नहीं चल रहा है, print नहीं जा रहा है. That's the role of CIO. This is a ground reality. We have to accept that. And we are talking about AI. Okay, I work for a company, GE Medical System. When I was there in 2000 in that GE Medical, we were talking about digital radiography. मैं अभी भी computer radiography देख रहा हूँ. BPL के साहब इधर खड़े, उनको they might be knowing what I'm talking about. अभी भी वही है. और our Indian people are ready to accept that. I'm telling you why. The fact is that now we are talking about digital. Now if I give you, if we give to the patient relative a pen drive to say that ये आपका images है, okay, they will not like it. अभी भी अपना है mentality side. People will write on WhatsApp, LinkedIn, everything about digitization. But when something happens to their relative, they would like to see that they are carrying all CT scan MRI images. They will go home. All relatives will sit together. Everyone will become doctor because ChatGPT is there with them. They will comment on that, but they will require the hard film. That is the ground reality of India. They will not like to have that small USB drive or some CD or whatever. Now DVD writer if it is given to them. So this is still the mentality I am talking. Now in hardware, the second thing is that earthing. Okay, very important for a server to have a good earthing, which has always been lack. HVAC. Like we said, dust-free environment. Is that dust-free environment is there or not? That is always a question mark. Because no one looks into that because ये सबसे ऐसा है department, वो है किधर तो? Okay, everyone wants to talk about all these things digitization, but no one is having time to see where is that department also, where is that server, where is the hub room. वो तो ऐसा एक low man land जैसा खड़ा रहता है. Because that should get a continuous power supply also, as well as we should have a HVAC also supply air conditioning. That is also most of the time. So I'm not talking about people who are sitting here, but people I'm saying in India, वो AC saving करने के लिए बंद कर देते हैं. फिर कहाँ से उसको मिलेगा? Then temperature goes up, for 30 degree, it can go up to 27, 28 degree, it can work switches, but then it will give a malfunction. So these are the problems which are there. Second thing is that when we say that the structured data, if you compare with the European countries, like they will come with their mobile, they will enter into hospital, everything is like insured there. So all the data is available on mobile. Okay, and then they will get all reports, everything, because EMR, HIS, LIS, everything is really synchronized. नहीं होता India में अभी भी. That is a real infrastructure. It's not possible. Still, we are not geared up for that because the data, whatever available with us, is not like a structured data. It is not like a longitudinal data. Means कैसा चाहिए कि like when patient comes, his entire history should be there. In our case, like episodic, जब भी वो आएगा डॉक्टर हॉस्पिटल में, whatever data, it is only digitized. What will happen after that? God only knows. Again, he will come back. No one knows also. Most of the time it happens that in India, when patient comes in ER, he may be in unconscious condition, no one aware what are the tablets he is taking. This is a basic thing what is there. So these are the infrastructure currently we are having some issue, but it doesn't mean that AI is definitely is going to be there, and it will be the future of this healthcare industry. So we cannot run out of that, but we should be ready basically with all the infrastructure for that, and the mindset should be there in such a way that, like I always believe that for any project to carry out, the sir has asked this question, team is always required. Without that, it cannot happen. But understand one thing, that team can perform if there is a good team leader. Otherwise, nothing will happen. Now, the question which he has raised, someone has to take that ownership. Now, this is the project, and I have to do it. And if that doesn't happen, the hardware also will not able to do anything unless until you are a proper team leader whose ideas are very clear why he wants to do AI. And he should be very clear that there are two things. Like if management will think, always think, is there a cost reduction is there? Okay, but the person who is running the show should be a clinical as well. Because what happens, most of the projects which are happens, what are hardware requirement, it is always some pilot project is done and then it fails. Because the reason is that no one knows what is the ROI also. Then who will take the ownership? Who is the team leader? So these are still the problems which are there as far as the hardware is concerned. But as I mentioned very clearly, we cannot run out of that. But if we say as a India across, still long way to go. But we should be hopeful that something will happen, because the way hospital will get built up, unless until that hardware setup is there, nothing can happen on software or AI part deployment. So that is a basic thing, we should able to learn that. And maybe next time whenever have AI this type of events, this architect also should be the part of that. Let them understand there is an importance for all these things. And when they will design, because currently also if you see, getting good people is always a challenge in hospital. So that is a one more challenge, because it's always like हम लोग बोलते हैं वो positive pressure है, patient है उधर मत जाओ, negative isolation में है. Now no one is ready from that background who wants to work on Saturday, Sunday, छुट्टी लेना है, 10 to 6 ही काम करना है. Now that mentality people to get in hospital infrastructure is the biggest challenge to maintain the hardware. So these are the reality of hardware in India.
Thank you so much, Neelesh sir. You have touched upon really the practical aspect to it. Since we are short on time, so I'm really sorry, we'll wrap up this session now. And thank you to all the panelists, all of you, for your precious time over here and for asking the questions. Thank you. Over to you, ma'am. Thank you so much.